Okay, thanks, Angela, for the introduction, and hello to everyone here and also on the other side, if you can hear me. So I will be covering the lymphoma part of the session today, and my goal was to cover a few abstracts from the recent ASH 2023 meeting, and also to highlight a couple of clinical trials of particular interest at UC Irvine. I have 4 abstracts listed here, though realistically, I think I'm only going to be able to get to the first 3. Okay, so the first one, I'll start with large B-cell lymphoma, and this study was presented by Martin Hutchings from Denmark, and looks at Glyphidimab monotherapy in relapsed refractory large B-cell lymphoma. And this is actually follow-up analysis, a long-term analysis of a phase 3 study, with particular interest in subgroups of patients that received prior CAR T cells, as well as looking at the impact of pretreatment tumor or total metabolic tumor volume in this population. So, patients with relapsed refractory DLBCL, especially those who have received at least 2 prior therapies, so the outcomes for these patients is historically quite poor. And while CAR T cells, as Dr. Churia just presented, have shown a significant benefit in these patients, also demonstrated in the previous presentation in the long-term results of the ZUMA-1 trial, the majority of patients still relapse after CAR T cells, so there's a need in this space for effective therapy. And so this is looking at Glyphidimab. So Glyphidimab is a CD20/CD3 bispecific antibody with a 2-to-1 format, which increases its potency and binding ability. And the principle behind these bispecific T-cell engagers is simply that one side of the bispecific antibody binds to the CD20 lymphoma cell, positive lymphoma cell, and one arm binds to the CD3 positive T cell, bringing them in close enough proximity such that it mediates T-cell dependent cytotoxicity. And so here, this is an extended follow-up, as I mentioned, of this trial. So this is a phase 2 study in patients with relapsed refractory large B-cell lymphoma, and to be included, all patients on this trial had received at least 2 prior lines of therapy. It included patients with DLBCL, high-grade B-cell lymphoma, and also transformed lower-grade disease, as well as primary mediastinal B-cell lymphoma. Patients had to have an ECOG of 0 to 1, and had, as I mentioned, have at least 2 prior lines of therapy, including an anti-CD20 antibody and an anthracycline. This is a fixed duration therapy. Patients received up to 12 cycles. And to mitigate the risk of cytokine release syndrome, patients received obinutuzumab IV prior to their first cycle. They had then a step-up dosing during cycle 1, and they went on to receive 30 milligrams of Glyphidimab with each cycle. And the primary endpoint here was CR rate as measured by an independent review committee. So here are the baseline characteristics of the patients in this trial, of which there are 154. And of particular interest is that these patients are very heavily pretreated. So sort of highlighted in the red boxes, so 60% of patients had received at least actually 3 prior lines of therapy, and 51 patients, or a third of the patients, had actually received a prior CAR. 89% of patients were refractory to any prior therapy, and 85% refractory to the most recent prior therapy. So when looking at response rates, so focusing just on kind of the metrics in the red box there, so the CR rate among all patients was about 40%, which is pretty good in this population, I would say, and with a median duration of response of 27 months. When looking only at DLBCL or transformed follicular patients, there was a similar CR rate of 44% with a median duration of response of 28 months. And importantly, when looking at patients that have received a prior CAR, so there were 52 such patients, 19 patients, or 37%, actually achieved a CR with a median duration of response of 22 months. And broken out to the right are the Kaplan-Meier regressions for kind of each of these subgroups that I mentioned. With each of these subgroups that I mentioned, with the solid gray indicating the prior CAR patients, the blue indicating all patients on trial, and the red line indicating only the patients with DLBCL or TFL that were included in this study. As I mentioned, the study also looked at the impact of total metabolic tumor volume and how that impacted outcomes among these patients. And so essentially what they did was they measured total metabolic tumor volume using a PET scan prior to therapy, and then split patients at the median. Those above the median were considered to have high tumor volume, and those below considered to have low tumor volume. Interestingly, patients with a low total metabolic tumor volume had much better outcomes, as shown in the blue curve, relative to patients that had a high total metabolic tumor volume, where the 24-month PFS rate was only about 12 months in the high group versus almost 42 months in the low group, suggesting that TMTV may be prognostic in these patients, at least for PFS. So it's important to consider the safety summary with these bispecific agents, and as expected, cytokine release syndrome was the most commonly reported adverse event. It occurred in 64% of patients, though was predominantly low grade, 48% grade 1, 12% grade 2, and most of these AEs actually occurred during that first cycle of step-up dosing. I don't have time to show that slide, but essentially most of those events, or most of those AEs occurred there. So in conclusion, the majority of patients that received Glyphidimab in this setting are in a CR, that achieved a CR remained in a remission at 24 months follow-up. The majority of patients with a CR at the end of therapy were alive and event-free 18 months after therapy, and higher baseline total metabolic tumor volume appears to be associated with response. And also, higher total metabolic tumor volume is associated with a greater risk of CRS. I didn't have a chance to show that slide. So overall, fixed duration Glyphidimab appears to provide a long-lasting remission in these heavily pretreated large B-cell lymphoma patients. So before going on to the next abstracts, I'd like to just highlight 3 trials in the LBCL space that are open at UC Irvine. These first 2 are in the front line. So the first one is interesting. It's UCI 2319 or Olympia 3. This is actually a phase 3 open-label randomized study comparing odronextamab, which is actually a CD3, CD20 bispecific T-cell engager in combination with CHOP versus traditional R-CHOP in untreated DLBCL patients. Patients can be included if they're untreated, have an IPI greater than 2, so it's not taking low-risk patients, and have an ECOG of 2 or less, and it excludes patients with CNS involvement. In older populations, there's a SWOG study open, S1918, which is actually a phase 2-3 randomized study of our mini-CHOP with or without oral azacitidine in patients 75 years of age or older. This includes DLBCL patients, patients with high-grade or grade 3B FL, patients with transformed low-grade disease, and high-grade B-cell lymphomas. Key inclusion, again, untreated disease, IPI greater than 2, 75 or older, and an EF of at least 45%, and CNS involvement is not included on this trial either. In the relapse refractory space, we have UCI 21225, which I think is a really interesting study. It's a phase 1B looking at the primary efficacy and safety of Glyphidimab, which is the agent I just discussed in the abstract, in combination with RICE chemotherapy in patients with relapse refractory, transplant eligible or CAR T eligible disease. So, to be included, patients patients must have had only one prior line of therapy, which includes rituximab obinutuzumab, an anti-CD20 antibody, along with an anthracycline. They must have an ECOG of 0 to 1, and they must be a candidate for either autotransplant or CAR. They cannot have CNS involvement. PMBCL is not included here, and they can't have received a prior bispecific antibody. All right, so the next abstract I'll discuss was centered on mantle cell lymphoma, and so this was a late-breaking abstract presented by Michael Wang from ND Anderson, and it looked at the combination of ibrutinib and venetoclax in patients with relapse refractory MCL, and this is results of the phase 3 Simpatico study. So as this audience knows well, and as we've discussed, ibrutinib is a once-daily oral BTK inhibitor that has been used in relapse refractory MCL as well as for many other indications. Venetoclax is a once-daily oral BCL2 inhibitor approved in multiple countries for CLL and AML. And the idea is that the combination of these two agents leverages complementary modes of action and has demonstrated synergistic anti-tumor activity in pretreatment in preclinical models as well as in earlier stage trials. So, again, this is a phase 3 randomized double-blind placebo-controlled trial, which enrolled 267 patients. Patients were adults. They had relapsed refractory mantle cell lymphoma. They had received between 1 and 5 prior therapies. They had to have received at least one anti-CD20 containing regimen and had a ECOG status of 0 to 2. They were randomized 1-to-1 to receive either the combination of ibrutinib and venetoclax, with ibrutinib given at 560 daily and venetoclax given at 400 milligrams daily after a 5-week ramp-up period. The placebo arm received ibrutinib daily at 560 plus placebo. Patients were treated for 24 months, after which they could receive ibrutinib single agent 560 daily until progression of disease or unacceptable toxicity, and the primary endpoint in this study was progression-free survival. So shown here are the baseline characteristics of the two arms, which are pretty well balanced in terms of age, progression, ECOG status, number of prior lines of therapy, and notably includes both mutated and non-mutated TP53 patients. So when considering the primary endpoint of this trial, which was progression-free survival, the combination of ibrutinib and venetoclax appeared to demonstrate superior progression-free survival relative to patients that received ibrutinib placebo, with the median progression-free survival in the ibrutinib venetoclax arm of about 32 months versus the median progression-free survival in the ibrutinib placebo month at about 22 months or 20 months, depending on whether it was investigator assessment or independent review committee assessment. So in considering overall response rates, I think this is interesting. So there was actually no clear difference between the two arms in overall response rate. However, there was a significant improvement in CR rate in the combination arm, the ibrutinib venetoclax arm, versus the ibrutinib placebo arm, as shown here with a significant p-value. And when looking at the duration of response among all patients that responded, the ibrutinib venetoclax arm demonstrated a median duration of response of 42 months versus about 28 months for the ibrutinib placebo arm. Overall survival, so this slide says overall survival was numerically improved. I think there's obviously no clear difference here yet in overall survival, though that may change as the trial matures. And certainly, given that we're combining two agents together, it's important to consider the adverse event profile of the combination therapy. And so there are more AEs here in the ibrutinib venetoclax arm, shown here on the left, including increased risks of GI symptoms like diarrhea, increased neutropenia here, increased nausea. Fatigue was pretty similar, but there was increased anemia as well. So in conclusion, ibrutinib and venetoclax achieved a statistically significant improvement in PFS compared with ibrutinib placebo. CR rates and time to next treatment, which is a slide I didn't show, which were significantly improved. Overall survival was numerically improved, but not statistically significant. And the safety profile was relatively consistent with what we know about these two drugs, with no new safety signals observed. All right. So the next study I'll talk about centers on Hodgkin lymphoma. And so this study was presented by Sarah Rutherford from Cornell, and this is a subgroup analysis of the SWOG S1826 study comparing nivolumab AVD to brentuximab vedotin AVD in patients with advanced stage classical Hodgkin lymphoma. And so this subgroup analysis focuses specifically on patients age 60 or above. So we know that modern classical Hodgkin lymphoma treatment is less effective in older patients. And while brentuximab vedotin in frontline improves outcomes in adults with CHL, the PFS benefit in older patients versus all comers is worse. So when looking here, the median PFS among all patients in these trials that get BV-AVD is about 82%. However, when you consider only patients 60 years or older, the PFS benefit is worse. And so shown here, the PFS benefit in this study, or the 5-year PFS among older patients receiving BV-AVD was only 67%. And we know that older patients, because of the bimodal distribution of Hodgkin lymphoma when it presents, comprise about 15 to 25% of patients. And these patients certainly have impaired tolerance to chemotherapy due to multiple factors. They often receive lower and attenuated doses due to toxicity, and they are more likely to suffer from treatment-related mortality. And so as a reminder for the overall design of the S1826 study, so this is a study, again, of newly diagnosed advanced stage 3 or 4 classical Hodgkin lymphoma. Patients were randomized 1-to-1 to receive nivolumab AVD for 6 cycles, with the nivolumab dosed as 240 milligrams on day 1 and 15 of each cycle, or brentuximab vedotin AVD with the BV dosed on days 1 and 15 of each cycle. And a key difference between the two arms is that growth factor was optional in the nivo AVD arm, whereas growth factor was required in the BV-AVD arm, and patients could receive radiation at the end of therapy to residual FDG-avid lesions. The primary endpoint of this study, again, was progression-free survival. So this is the inclusion criteria, again, of the whole trial. We're only going to look at the older patients, but patients in this trial were over 12 or older. They could be HIV positive if it was controlled. Their performance status had to be between 0 and 2. They had to have an adequate ejection fraction of at least 50%, as well as adequate kidney and liver function. They were excluded if they had interstitial lung disease, grade 2 or greater peripheral neuropathy, or active autoimmune disease. So in considering the baseline characteristics of these older patients, the majority were, so there were 48 and 49 patients on the two arms in this subgroup analysis. The majority of patients were between 60 and 69 years of age, though there were a couple patients over 80 years old. They were also well balanced in terms of gender and race. And also the patients on the Nivo-AVD arm appeared to have more adverse risk factors, especially there were more in the Nivo-AVD arm. There were more patients with stage 4 disease and more patients with bulky disease of greater than 10 centimeters. So I'll first talk about the difference in the adverse events between these two groups. So there were globally more AEs within the BV-AVD arm versus the Nivo-AVD arm, with higher rates especially of GI symptoms, GI issues, neuropathy, and sepsis. And we'll go through kind of each of these one by one. So looking first at hematologic AEs, there were higher rates of neutropenia in the Nivo-AVD arm relative to the BV-AVD arm, though it's important to note, again, as I mentioned before, that growth factor was not required in the Nivo-AVD arm, so only 69% of patients in the Nivo-AVD arm got growth factor, as opposed to 92% in the BV-AVD arm where it was required. When considering anemia and thrombocytopenia, there were higher rates of severe anemia and thrombocytopenia in the BV-AVD arm as opposed to the Nivo-AVD arm. There was also more sepsis and an increased rate of infections with BV-AVD relative to Nivo-AVD, which is shown here. So essentially 6% of sepsis, 6% rate of sepsis in the Nivo-AVD arm and 21% in the BV-AVD arm. Also higher rates of infection. No clear difference in rates of febrile neutropenia. There was, as you would expect with these agents, there was a higher rate of peripheral neuropathy. There's a significantly higher rate of peripheral neuropathy in the BV-AVD arm versus the Nivo-AVD arm. And when considering other AEs of interest, including autoimmune or immune-related AEs, they were relatively uncommon, though the Nivo-AVD arm did demonstrate increased rates of hypothyroidism and rash relative to the BV-AVD arm. Really importantly, when looking at the rates of completion between these two regimens, 88% of patients in the Nivo-AVD arm completed treatment as opposed to only 63% in the BV-AVD arm. And when looking at death on treatment, 1 patient in the Nivo-AVD arm died on treatment as opposed to 5 patients or 10% in the BV-AVD arm. So when looking at the primary endpoint of this study, which, as I mentioned, was progression-free survival, there was a significant improvement in PFS with Nivo-AVD outperforming brentuximab vedotin-AVD in this setting, with 1-year PFS rates of 93% versus 64% in the two groups, with a median follow-up of 12 months. When looking at OS, there were fewer deaths on Nivo-AVD as opposed to BV-AVD, with 1-year overall survival rates of 95% in Nivo-AVD and 83% in BV-AVD. Additionally, the majority of deaths on BV-AVD were actually due to infection and sepsis, and the non-relapse mortality rate between the two arms was quite different, with 4% in Nivo-AVD and 14% in BV-AVD. So in total, this suggests that Nivo-AVD is better tolerated in this older population than BV-AVD. There were more GI AEs, sepsis, infections, and peripheral neuropathy with brentuximab containing regimen. There were low immune rates with Nivo-AVD, immune event rates with Nivo-AVD, similar to the study population. And importantly, more patients discontinued brentuximab than they did nivolumab. And so the take-home message from this presentation really is that Nivo-AVD substantially improves PFS compared with BV-AVD in older patients. EFS was also improved, though I didn't have a chance to show that, and fewer deaths occurred on Nivo-AVD. So I won't have time. I'd hope to show one further study. I won't have time to show that, but I would like to just highlight one additional trial that is open at UCI in follicular lymphoma. So in the relapsed refractory setting for follicular lymphoma, we have open ZUMA 22, which is a phase 3 randomized open-label multi-center study evaluating axicabtagene ciloleucel, so CAR T cells versus standard of care therapy in relapsed refractory FL. Patients can have grade 1, 2, or 3 AFL. They have to be relapsed refractory after their first line of therapy, as well as high-risk disease. They have, it's a little complicated, they can have progressed within 24 months of their most recent therapy, which is POD 24, or they can have received at least 2 prior lines of therapy. And they have to have a clinical indication for treatment. Study excludes patients with a history of transformed disease, patients with FL3B, and patients that have received a prior CAR or CD19 targeted therapy. And I think I'm at time there, so I'll stop there.